Nasogastric Tube Feeding by Mahina Rachel in BSN2 Mercer. So what is NGT? Nasogastric tube feeding is the installation of specially prepared nutrients into the stomach through a nasogastric tube. And for assessment, assess client need for internal tube feedings, impaired swallowing, decreased level of consciousness, head, neck surgery, facial trauma, surgeries of upper alimentary. Rationally identify clients who need tube feeding before they become nutritionally depleted. Auscultate for bowel sounds before feeding. Rationally absent bowel sounds may indicate decreased ability of gastrointestinal tract to digest or absorb nutrients. And obtain baseline weight and laboratory values. Assess client for fluid volume excess or deficit, electrolyte abnormalities, and metabolic abnormalities such as hyperglycemia. Rationally, enteral feeding is to restore or maintain a client's nutritional status, provides objective data to measure effectiveness of feedings. Let's verify physician's order for formula, rate, route, and frequency. Laboratory data and bedside assessments such as finger, stick blood, glucose measurement are also ordered by the physician. Rationally, tube feedings, laboratory test, and bedside test must be ordered by the physicians.
Step number 1. Explain the procedure. Discussion and explanation help allay anxiety, encourage patient cooperation, and prepare the patient for what to expect. Second, perform hand hygiene to deter the spread of microorganisms. Third, prepare feeding container to administer formula. Rationally cold formula may cause gastric cramping and discomfort because the liquid is not warmed by mouth and esophagus. Have tube feeding at room temperature. Connect tubing to container as needed or prepare ready-to-hang container. Tubing must be free contamination to prevent bacterial growth. Shake formula container well and fill container and tubing with formula. Filling the tubing with formula prevents excess air from entering GI tract. Place client in high Fowler's position or elevate head of bed 30 degrees. Elevated head helps prevent aspiration. Fifth, determine tube placement. Aspirate gastric contents to check for gastric residual. Return aspirated contents to stomach unless the volume exceeds 150 ml. Rationally, presence of gastric secretions indicates that the distal end of the tube is in the stomach. Residual volume indicates if gastric emptying is delayed. Delayed gastric emptying may be reflected by 150 ml or more remaining in the client's stomach. Measure pH of aspirated GI contents. Imagine this is our measuring pH. Fasting gastric pH is usually equal to or less than 4. It is only infrequently greater than 6. In contrast, intestinal aspirates usually have a pH equal to or greater than 7. Observe the aspirate's appearance. Gastric fluid is usually cloudy and grassy green or tan off or white in color. In contrast, intestinal fluid is usually deep golden yellow and is clearer than gastric contents. Consider the results of pH testing and aspirate's appearance together. An aspirate with a low pH and typical gastric fluid color indicates a high probability of gastric placement. In contrast, a golden colored aspirate with a high pH indicates a high probability of intestinal placement. Initiate feeding. Bolus or intermittent feeding. Pinch proximal end of the feeding tube. Remove plunger from syringe and attach barrel of syringe to the end of tube. Prevents air from entering client's stomach. Fill syringe with measured amount of formula, release tube, and hold syringe high enough to allow it to empty gradually by gravity. Refill, repeat until prescribed amount has been delivered to the client. If feeding bag is used, hang feeding bag on an IV pole. Fill bag with prescribed amount of formula and allow bag to empty gradually over at least 30 minutes. Gradual emptying of tube feeding by gravity from syringe or feeding bag reduces risk of abdominal discomfort, vomiting, or diarrhea induced by bolus or too rapid infusion of tube feedings. Continuous drip method, hang feeding bag and tubing on IV pole. Continuous feeding method is designed to deliver prescribed hour rate of feeding. This method reduces rest abdominal discomfort. Clients who received continuous drip feeding should have residuals checked every 4 hours and tube placement verified. Connect distal end of tubing to the proximal end of the feeding tube. Connect tubing through infusion pump and set rate. Advanced tube feeding gradually. Tube feedings should be advanced gradually to prevent diarrhea and gastric intolerance to formula. When tube feedings are not being administered, cup or clamp the proximal end of the feeding tube. Prevents air from entering stomach between feedings. Administer water via feeding tube as ordered with diluted formula. Provides client with source of water to help maintain fluid and electrolyte balance. Rinse bag and tubing with warm water whenever feedings are interrupted. Rinsing bag and tubing with warm water clears all tube feedings and reduces bacterial growth. Measure amount of aspirate or residual every 4 hours. Evaluates tolerance of tube feeding. Monitor finger stick blood glucose every 6 hours until maximum administration rate is reached and maintained for 24 hours. Rationally alert nurse to client tolerance of glucose. Monitor intake and output every 24 hours. Rationally intake and output are indications of fluid balance or fluid volume excess or deficit. Wait client at daily until maximum administration rate is reached and maintained for 24 hours. Then wait client 3 times per week. Rationally, weight gain is indicator of improved nutritional status. However, sudden gain 2 lb in 24 hours usually indicates fluid retentions. Lastly, observe the return of normal laboratory values. Improving laboratory values, example, the albumin, transferrin, and prealbumin indicate an improved nutritional status. Thank you and God bless.